this is actually the Ether Dome at Mass General. This is where the first operation was performed in an open theater. And actually, that's still a conference room today. So that's where we've been. And this is the hospital today, quite a busy place. And this is where we've been with cord blood. So this is the report of the first cord blood transplant done in 1988 in France in a child with Fanconi's anemia. And this child is now an adult and healthy. And so we'll be celebrating next year the 25th anniversary of the first cord blood transplant. And this is a work done by Dr. Mary Laughlin, who's in the audience and is on the program tomorrow. This was actually the first report of adult cord blood transplantation. And I just want to point out a few things. So this is a very important finding that if you gave more CD34 positive cells, a higher stem cell load, patients did better. And so that really set the pace for trying to improve cell dose, either by using larger or expanded single cord blood units or by combining units in double cord blood transplant. And this is the total number of cord blood units in inventory. I think Greg showed you some of this data, but now at about 500,000 public cord blood units worldwide and listed for transplant physicians to use in a bone marrow donor worldwide search, all done on computer. And this is data from our registry, the Center for International Blood and Marrow Transplant Research, showing the growth of unrelated cord blood transplantation. As you can see, this is the blue is the children, and the green is the adults, with the last 2 years not exactly complete data, but there's been growth in both the pediatric and the adult populations. So the initial transplants were done in children because of the concern over cell dose, and then later extended to adults. And over 25,000 cord blood transplants now have been performed worldwide, with about 500,000 umbilical cord blood units donated to public storage banks, with banks in several different countries. So the upper age limit of transplant in our program now has been extended up to age 70. When transplants were first done in Seattle in the late 60s and early 70s, the upper age of transplant was 30. And the joke in the field is that as the transplant physicians get older, so does the upper age limit of patients that would be deemed suitable for transplant. Survival outcomes continue to improve, and one of the things that we're studying are both myeloablative, traditional high-intensity regimens, often requiring total body radiation, and more what we call reduced intensity regimens or mini transplants, which are more immunosuppressive, or a little bit safer for the patient and allow us to transplant older patients. The best results are with greater than 4 out of 6 matched units or better than that, and a cell dose of 3 × 10⁷ nucleated cells per kilogram. So we see that both the cell dose and the HLA match are important. But even with these advances, infection and poor immune recovery remain major challenges, and that is the major cause of death for patients after cord blood transplant, that and relapse disease. This is data from EuroCord, which is a registry of many different cord blood programs in Europe. And this is looking at adults receiving 1 cord blood unit using a myeloablative regimen. And as you can see, results are improving slowly from the 1990s to today. But still, we're losing a lot of patients after cord blood transplant, and there's still a lot of room for improvement. Now, what about single versus double cord blood transplant? So the initial transplant, we're all using 1 cord blood unit or single cord blood transplant. And that is really the standard right now in pediatrics. It is certainly less expensive because it's costing now somewhere between $35,000 and $40,000 US to obtain each cord blood unit. So if you talk about a transplant center, in a hospital that's on a fixed budget, in other words, the insurance company will give a fixed amount, $150,000, $200,000, to the hospital for the entire care of that patient through the transplant. If you're spending $80,000 just to obtain the cord blood units, hospitals are going to start to lose money, and they will be less likely to want to do this procedure. So single cord blood transplant is definitely less expensive. There is a large randomized study in pediatrics operated by our CTN, which stands for our Clinical Trials Network, of single versus double cord blood. This study has recently completed accrual, and publication of the results is pending. But this will be very important to see, at least in children, if there's an advantage to using 2 versus 1 cord blood unit. Now, for double cord blood transplantation, that is definitely more popular in the United States than overseas, and the reason being is that as a population, in the US we're 10 kilograms heavier than our colleagues in Europe, and 15 kilograms heavier than our colleagues in Asia. So we are fat. And I hope everyone enjoyed breakfast. But this is one reason why double cord blood transplant is a lot more popular in the United States. Some preliminary data shows that when you use 2 units, the risk of relapse might be less, but your risk of graft versus host disease might be higher. And conceivably, as we learn more, there might be certain segments of patients or certain diseases that we think might do better with 2 versus 1 cord blood unit. And in most double cord blood studies, engraftment is quicker by a few days, but immune recovery still is an issue, and infection is still a major concern, even with using 2 cord blood units. So we have not solved that problem. What are some critical concerns with cord blood? Well, it is a one-time donation, so you can't go back to the baby and ask for more cells. And this is an important issue because the National Marrow Donor Program has found in about 10% of cases of patients receiving unrelated adult bone marrow or peripheral blood stem cells, there is a request for a second, either a second transplant because the patient didn't engraft, or donor lymphocytes because the patient relapsed. So that option is not possible in cord blood. We talked about the cost, and this, I will tell you, is going to become a huge issue because there are other graft sources like haploidentical transplant, taking a mismatched family member, that's a lot cheaper and a lot easier to do. So either cord blood we have to figure out how to do it a lot more cost effectively, which I hope everyone in the room can focus on, or we have to do it better and make sure that our outcome results are better. We know that cell dosage is an important factor for engraftment. The average size of most bank units is about 120 times 10 to the 7th nucleated cells. So and we really want to get a cell dose of about 3 times 10 to the 7 nucleated cells per kilogram, which means that most of the units that are banked are not going to be sufficient for adults. They may be sufficient for children or maybe very small adults, less than 40 kilos, less than 100 pounds. So that is an important problem, and as I mentioned, even more so in the US because of the weight issue. So what are some ways to get around this? One is expansion of cord blood units, and there are several ex vivo expansion trials. Colleen Delaney is in the audience, and her group has done a number of work on different ways of expansion, or the use of 2 cord blood units. There are improved collection and banking techniques and ways of picking cord blood units that might be more appropriate for each individual patient. So what are our choices of donors? Well, a fully matched sibling donor. So each sibling has a 25% chance of matching. The alleles are inherited by strict genetics. And for most Americans, that means about a 30% chance of finding a matched donor in the family. In certain cultures where there are much larger families or where intermarriage, consanguinity is part of the culture, then of course it's much easier to find donors. But in the US, it's about a 30% chance of finding a match in the family, completely matched sibling donor. So then those patients are entered into the registry to look for matched unrelated donors, and only about 20% of patients who come from a minority racial or ethnic group are able to find a fully matched unrelated donor. Cord blood would be our next option, and we'll talk about that obviously some more. The other option would be a mismatched family member, or what we call a haploidentical donor. So that would be someone who's a half match to the patient. And if you think about it, most patients will have either a child that's a half match to them or a parent that's a half match to them. So most patients will have a haploidentical donor, or a mismatched unrelated donor is another possibility. Traditionally, those transplants have been associated with a high risk of graft versus host disease, but more recently, with better techniques for HLA typing and other supportive care, results are improving for this group as well. So these are all the options that myself and my colleagues as a transplant physician would go through when we're seeing a patient with leukemia or lymphoma that needs a transplant. Now, if we compare cord blood with other graft sources, there's been a number of studies that have looked at this. The first important point is that there have been no prospective randomized studies to date to compare cord blood with other graft sources. So the honest answer is we really don't know which is best. That is often very frustrating to patients to tell them that. This is a study done by Mary Eapin and looks at adults age 16 and older with acute leukemia. This is a retrospective study from various registries and looks at over 100 patients who receive a cord blood transplant and compared those to similarly matched patients, similar cohort of patients who received unrelated either peripheral blood stem cell or bone marrow transplant. And this study used only single cord with a sufficient cell dose greater than 2.5 times 10 to the 7th nucleated cells per kilogram, and a 4 out of 6 or better match with myeloablative conditioning. Transplant-related mortality, the chance of dying in the first 100 days after transplant, was higher in the patients that received cord blood. But acute and chronic graft versus host disease was actually lower in the cord blood patients. And so when the results were analyzed at the bottom line, leukemia-free survival, disease-free survival was comparable across all groups at 41%. And what was shown is really the choice of whether you use cord blood or unrelated bone marrow was less important than certain characteristics of the patient, so that the age and their status of disease, whether they were in remission and how long they had been in remission, were the most important factors for survival. So this study would suggest that cord blood is equivalent to unrelated bone marrow and certainly should be considered in the graft sources algorithm for patients that don't have a fully matched sibling donor. But I just want to call the attention to the fact that leukemia-free survival at 41% is still not where we'd like to be. And so that there's definitely room for improvement, not just with cord blood, but with transplant in general. And these are a couple of other series that have also looked at myeloablative conditioning, again, retrospective series. One study from Japan. Now, in Japan, their cord blood results actually are extremely good. You can see a disease-free survival of 70% with unrelated cord blood. And one reason why that, there are a couple of reasons why that might be. One is the population is smaller. The other is that it's island population, more genetically homogeneous. And so a match, 4 out of 6 match in Japan between a Japanese donor and a Japanese patient might be closer together than a 4 out of 6 match in the US between a US donor and a US patient. But their results were comparable between cord blood and match-related donor, both for relapse, transplant-related mortality, graft versus host disease, and survival. So actually in Japan, unrelated cord blood is the choice graft source for patients that don't have a sibling donor. They do very few unrelated bone marrow transplants. And this is a series from the US looking at patients in Minnesota and Seattle, comparing cord blood with matched sibling donor and matched unrelated donor and mismatched unrelated donor. And similar to some of the other series, we saw that the patients that received cord blood, their chance of relapse was lower, but their chance of dying in the first 100 days was greater. But then when we get to kind of the bottom line in terms of overall survival, leukemia-free survival, it was comparable. About 50% for cord blood, 33% for match-related donor, 48% for the unrelated donor, and 38% for a mismatched unrelated donor. And these were all statistically comparable. So basically, these 3 studies have shown that if you use myeloablative conditioning, disease-free survival seems to be comparable between cord blood and matched unrelated donor. And for reduced intensity conditioning, this is a study from our group here in Boston by my colleague Dr. Chen. And this is comparing in a reduced intensity conditioning, so the regimen is fludarabine based, and it's comparing double cord blood with unrelated donor, and results also are comparable for this group as well. Now, how about haploidentical transplant? As I mentioned, most patients are going to have a haploidentical donor. It's likely that a parent or child would be a half match or possibly a sibling as well. Not everyone, but many patients will. And it's certainly an easier transplant to facilitate because you're not waiting for a cord blood unit to arrive from overseas and things like that. So this was a study that was done in our clinical trials network. It is not a randomized study. It is 2 phase 2 studies that were done at the same time with similar eligibility criteria. All patients received a reduced intensity conditioning regimen, so which was fludarabine, Cytoxan, and low-dose radiation. And patients received either double cord blood transplant or a haploidentical transplant match with what we call a Hopkins approach with post-transplant Cytoxan. Again, like the myeloablative studies, we see that there's a higher transplant-related mortality with cord blood, but the relapse rate was lower. And at 1 year, overall survival and progression-free survival were similar. Now, the cord blood folks, including myself, will say that the follow-up is really too short to assess for late relapses. So we know that we lose a lot of cord blood patients up front, but if we're concerned about relapse, we haven't taken into account patients who might relapse after 1 year with this analysis. And this was a retrospective study. So now there's a large randomized study in progress. This is a very ambitious study of over 400 patients nationwide. And it really calls on us in the transplant field to kind of give up our prejudices of what we think might be better and offer patients this opportunity. It is a complicated study for patients to undertake because they will need to find both double cord blood units that match them and a haploidentical donor that match them up front. An insurance company needs to approve this idea, then they will be randomized, and to one of these options. So this study is just opening, and I think it will be a very important study for us to see the results. And now to kind of move on to things that we need to do to improve cord blood. I think that they are really strategies to improve engraftment and immune recovery. These are really the main problems. So one is on cord unit selection. So in the beginning, it was all cell dose and HLA match. And while we know these are still probably the most important factors, there may be other factors that we really have ignored for the first 25 years that might be important. One are antibodies against different HLA alleles. Those have been associated with poorer survival, and I'll show that. What about HLA-C, which we know is important for unrelated bone marrow matching, but really has not been looked at or considered in cord blood search strategy. And this might be something else to focus on. And the group in New York has looked at the non-inherited maternal allele. So they've saved maternal DNA on all their cord blood donors, and they've gone back to type them. And if there's a match between the allele that's not even inherited in the cord blood unit and the patient, then those patients do better. Ex vivo expansion. There are multiple strategies, which I won't have time to go into all of them. There's the NOTCH strategy in Seattle, mesenchymal stem cells, the group in MD Anderson is doing, and our work, which I'll show you briefly on prostaglandin E2. And then there's also the strategy of taking the best of both worlds and combining haploidentical and cord blood transplant. And this is several programs. This was initially pioneered in Spain using single cord blood plus a haploidentical donor. And now there's data in both the myeloablative and reduced intensity setting. So these are some ways that we're trying to move the field forward. And just to illustrate a few of these, this is data done by my colleague Corey Cutler, looking at the presence of HLA antibodies and outcomes after double cord blood transplant with a reduced intensity regimen. So we looked at 73 patients. They all had a greater than 4 out of 6 or greater allele level match, double cord blood with a reduced intensity regimen. Now, 22% of patients had an HLA antibody versus either one or both cord blood units. And if you did that, you had an increased risk of graft failure that was actually up to 57% if you had antibodies versus both units. And when we looked at survival, the numbers of patients are small. If you have no antibodies against unit, the survival was 45%, and if you had antibodies directed against both cord units, because you're more likely to reject them, there was actually 0 survival, and that was statistically significant. So in our program now, we test everyone for HLA antibodies up front when we start their search, and again, just prior to transplant, and we don't select units that the patient may have antibodies against. This is our work on prostaglandin, which is a way of expanding the cord unit. This is work done in a murine model showing that if you incubate cells with prostaglandin, you're going to get more colony-forming unit progenitors. And now this is part of a phase 1 clinical study, again using double cord blood transplant where one is expanded and one is untreated. And what we've shown is our median, in a small group, a median time to engraftment is decreased by about 4 days. And the unit that appears to be dominant appears to be the prostaglandin treated unit in the majority of patients. And now we're taking this to a larger study looking at single cord blood that's expanded. So immune reconstitution and infection remain significant problems. There's poor immune recovery even after double cord blood transplant. I mentioned some strategies to improve immune recovery, such as ex vivo expansion. I want to show you some data on cytotoxic T lymphocytes. This is work done in Houston, the group at Baylor, looking at cytotoxic T lymphocytes directed against 3 main viruses that we see after transplant: adenovirus, Epstein-Barr virus, and cytomegalovirus. And these lymphocytes are off the shelf. They're not matched in any way. And this is the data looking at 44 patients with about an 82% response in terms of decreasing the viral load in these patients. And this is pretty significant considering this is a major cause of death after cord blood transplant. So we're excited about this work as well. So in conclusion, we've seen a significant growth of both cord blood banking and transplant and improved outcomes for children and adults. Several large retrospective studies have shown comparable or even superior outcomes to cord blood versus matched unrelated donor or match-related donor transplant. There's been work in the myeloablative reduced intensity setting, and cord blood transplants have spread pretty significantly, mostly in the US, Europe, and Asia. And it's exciting to see that our first randomized study comparing graft sources is underway. So in terms of the future, I think we need better cord blood selection techniques, ex vivo expansion strategies, strategies to do with immune recovery and infection, and I think to address the cost issue, if we use more cord bloods, there's increased utilization and demand, the costs will decrease. So thank you very much.
We have time, I think, for at least one question, and then we'll move on. Or, okay, hearing no questions, Karen.
No, it's a very quick one. At the end, in your improvements for the future, one of the things that strikes me as critically important is the ability for transplant centers to easily search all the available units out there. And there's a lot of wheat and chaff there, and the selection, not just the correct selection, the way data is displayed to transplant centers and the ease of searching and comparing cord blood units. Would you
I think that's gotten a lot better. So when patients need, if they don't have a donor in their family, they go through the NMDP, be the match strategy, and out will come all the available bone marrow, peripheral blood stem cell, adult donors, and also cord blood units, searching several international registries. I think there are a few that are still not hooked up with the NMDP, but they are very few. So I think it's gotten a lot better.
Okay. All right. Thanks, Karen.
Okay, great. Thank you.
All right.